Hey, Pulse Potties. Thank you so much for all of you who came out to the show on Tuesday in Sydney at Glee Books, where you got to meet Charlotte Blees of Dr. Bot book fame. Charlotte and I were so pleased to have you at the launch. It was great to hear from so many of you and how you really enjoyed the book launch and the conversation. For those listeners who are in Melbourne or going to be in Melbourne on Tuesday, the 10th of March, you can come and see Charlotte and I at the book launch for Dr. Bot at Mary Martin Bookshop in South Bank. See the link in the show notes for where to get tickets. Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topics show and I'm your host, Louise Schaefer.
And I'm your other host, George Margolis.
So George, considering what time it was when you sent me a snippet of your evening last night, I'm amazed that you're up bright and early this morning. How are you feeling?
I'm feeling good. Greek wine seems to have very little negative effect on me, which is great.
So tell us, what did you get up to?
Look, it's been a busy couple of weeks here. I've been over in Greece. Athens Digital Health Week was where I came over for. It was very interesting. Lots of talk about AI, but also a lot of talk about how you still need to get a lot of the fundamentals right. So it does reflect very much what we're seeing around the world. Lots of research being done here, but there seems to still be that disconnect between what's happening in the research labs and what's happening on the ground.
Wow.
And yeah, they're working on how to fix it. And interestingly, a lot of what our stuff we did in Australia with the CXIO network and that idea of getting clinical engagement is still sort of coming to ground here. So I think there's lots of opportunities there for both engagement around education and career growth.
Yep.
But I have to the most interesting thing here was the discussion around the European health data space. I think that's something we should keep an eye on because that's a really big initiative to enable them to promote data sharing across the whole continent for both research and for improvements of their AI models.
Absolutely. We will keep an eye on that. And you're moving over to Spain soon. Is that right?
Yep. So over to Barcelona for the Global Health Connector Summit, which is the old ECH Alliance being rebranded as Global Health Connector. And again, following up there a lot on that collaboration across borders. So Europe seems to have done a fairly good job in collaborating across their various quite different healthcare systems. But the one thing I do like is that if you look at all the European healthcare systems, they are very citizen-focused. They're really designed to provide services to citizens and very much a public healthcare system like ours in Australia, although, again, multiple different models. Lots of discussion over here around open EHR, so I think that's sort of getting a lot of traction. Interesting now with Rachel moving from open EHR to HL7, how those two worlds are merging. So I think there's lots of opportunities for us to explore there.
Yes.
One of the things we are doing in Barcelona is working on the Asia-Pacific version of the Global Health Connector model. It's being based out of Singapore, but having a regional role. I think that'll open up opportunities. And this time I'll be having tapas and sangria instead of a souvlaki and ouzo.
Yes. With Geordie, probably, I guess. You're going to be seeing him?
With Geordie, absolutely.
Cool.
But what about you, Louise? How's the last fortnight been in Down Under?
Oh, man. Well, yeah, that's probably the coolest thing I've done in the last fortnight is I got to meet Charlotte Blees in person. And yeah, she's only here for, I think, like a month or just a bit under a month. And so I love Melbourne and I love having international visitors and showing them around and taking them to places that tourists wouldn't necessarily know. We've caught up once and we did this big long walk around Albert Park Lake. And that night I was so tired. I looked at my watch. I had done 29,000 steps.
Wow.
And that is my record because I think before then it was when I was with Danny Sands in Boston and he took me around Boston and I did about 25,000 steps that day. But yeah, Charlotte and I got up to 29. So I was very pleased with myself.
Well, looking forward to hearing more about the launches. I hear they've been pretty well subscribed. So there should be lots of interesting stuff coming out of that. And then we're together to the Australian Digital Health Week after that. So
we will.
We'll be spending a bit of time together the next couple of weeks, which is great.
Always good in my book. Shall we get to our hot topics, George?
Let's jump in.
All right, we have lots of innovation-related stories this week, but the one that we're covering first is the one making headlines around the world. Yes, we are talking about one of the most significant exits in Australian digital health history. Eucalyptus Health, a Sydney-founded telehealth platform launched only in 2019, has agreed to be acquired by US-listed health giant Hims& Hers. And this is a blockbuster deal valued up to 1.6 billion Australian dollars. Yes, you did hear that right. Now, for a company that began with a men's telehealth brand and now operates across Australia, the UK, Germany, Japan, and Canada, I believe they have over 700,000 customers. So this is more than just a financial milestone. I think it's really a signal of how these different digitally enabled care models are maturing and their acceptance in the marketplace into this world of becoming global consumer health infrastructure. So not health system infrastructure, but consumer health infrastructure. The deal is going to see Eucalyptus co-founder and CEO Tim Doyle. He's going to transition to Senior Vice President of International at Hims& Hers, overseeing operations outside the US. And Eucalyptus's suite of brands, which is weight management, men's health, fertility, reproductive care services, that's all going to be gradually folded into this broader global platform. So, George, does this massive deal signal a deeper evolution in digital health, like something where virtual care and online prescription models, which was once a very much COVID-era experiment, now becomes credible, investable, and central to that future architecture of health services globally?
Yeah, you're right. It's not often that digital health gets both onto Sky News and this Australian Financial Review. And the story of Eucalyptus acquisition has sort of been over all of us. I've had so many notifications pop up on my screen and people ask me about it. I'll be open. I wasn't a big fan of Eucalyptus, not because they were doing anything wrong. They put a lot of time and effort making sure they stayed within the rules. But I just didn't like the fact that healthcare was being fragmented and the companies are running off with their lucrative path of healthcare and leaving the rest of the problems on the table for the existing healthcare system to manage. There were some questions early on about their processes, but to their defense, they jumped in and fixed those pretty quickly. So they actually introduced clinical governance. They did a pretty good job of staying within the confines of what their model was. Their brands were obviously pretty good at marketing because they managed to target lots of fat, bald people like me, or people who had reproductive issues, or people who had other issues. I mean, it was done fairly tastefully. I mean, I've seen some fairly tasteless ads for the same sort of businesses from around the world. I'm sure many people were tempted, obviously, to use it. I did get a chance to visit their offices once during a startup event, and I must admit, it was a pretty cool office space. There was a really hip vibe about it. There was beer flowing. There was good food flowing. There was interesting discussion. They rode that GLP-1 wave really well. I mean, they took advantage of the fact
that... Yes, because they were around before then, weren't they? But then the GLP-1 stuff happened and they took advantage of it and really skyrocketed their growth.
Exactly. And look, that just reflects on the fact that the regular healthcare system is slow to adopt some of these trends. And a lot of my colleagues who are in general practice prescribe GLP-1s quite regularly, but obviously don't promote it. Then it's just not part of the way the healthcare system works. They weren't prescribing anything that wasn't available to any other doctor in Australia to prescribe. Anyone with a prescription pad and APRA registration could have prescribed the GLP-1s, the erectile dysfunction drugs they were prescribing, the hair loss tablets they were prescribing. The fertility treatments were, again, nothing revolutionary. They weren't doing anything that wasn't mainstream medicine. They were just doing it in a different model of care, not linked to health insurance models. That they managed to did it well. And interestingly, and I went and looked at some of their financials, they're still not profitable. So $1.6 billion for a company that's still running at a significant loss. And if anything, their losses are growing rather than shrinking.
That's the thing, these sort of deals, it's not just about the money, it's about the footprint, isn't it? Because Hims & Hers, they're solely US based. So if they want to become a global company and knock on Australia's doors and knock on Germany's doors and Asia Pac doors, like the amount of work they would need to do in regulatory compliance and all of these things and learning the local system, whereas it's probably way easier for them and cheaper in the end to purchase a company that already has gone through those regulatory headwinds and faced that scrutiny and has come out the other side.
And Tim Doyle has been quite open that effectively he was copying the Hims & Hers models here in Australia, then taking to other countries. So, and his new role as international lead is obviously a reflection on his skills in doing that. Tim and his team will come out of it well. Again, it is a complex deal, so there obviously are some requirements around it. So whilst we keep on hearing this big $1.6 billion number, that isn't going all into the CEO's pocket. There's obviously a lot of shareholders who are...
I believe it's a deal over time as well.
Yeah.
Tim and people who stay under him, I believe they'll have targets they have to hit over a period of time, which will be about footprint growth, profitability that will actually impact getting all of that 1.6 billion.
But what it does show is also that Australian startups have not been very good up to now is having exit strategies, working out what they do once they've started their companies. Then this is a good example of growing your company rapidly, doing all the stuff that Silicon Valley loves, and exiting a point which is both beneficial for the shareholders and for the people involved without losing the company. The services will continue to be delivered here in Australia, maybe under a different brand name. And they'll have opportunities to do other innovations in Australia. Now, whether they do that under hims and hers or whether they become sequential startup entrepreneurs, we'll have to watch and wait. Hopefully they'll use some of that funding and also some of that knowledge and share it with other Australian startups so we can help grow our startup community here locally.
Yeah, and that is a really positive thing. Australia's a pretty small market, and it's something that we hear from the startup community all the time, just how difficult it is to scale. And many of them have their first sales, especially when they're enterprise-based systems, to international organisations rather than local. But to see a local company that saw a gap in the market and they've done really well. And so that actually goes to show that Australian startups, you can have global success. And from an individual level, yes, the payouts for those early 100 staff is going to be quite substantial. There's going to be many millionaires amongst them, which is wonderful at an individual level. And also there'll be many staff, I believe, who will still be bringing in $400,000 or more. Yeah, it's a positive news story for all the people who believed in Eucalyptus's vision and helped them have the success they've already had. So we will keep an eye on how Eucalyptus and hims and hers goes. But yeah, huge news story. And like you said, covered by financial outlets, health outlets all around the world. So we certainly wanted to touch on it today. Our next story, George, we've talked before about the RACGP Hackathon that I'm very excited to be co-facilitating, which is coming up in March. But here we have a story about a hackathon on a global scale. So recently, Anthropic launched a global Claude hackathon, and Claude is their AI tool for those who haven't used it. Now, this was a great strategy to showcase what's possible with the new suite of Claude Gen AI tools. So especially the vibe coding stuff where you don't need to be a coder to build software. You can basically use everyday language to describe what it is you want to build. And then Claude Gen AI is going to go and do all the coding for you. Now, apparently there was over 13,000 applicants. And amongst such a diverse and no doubt talented group of people, the guy who placed third was a cardiologist from Brussels, Dr. Michel. And I can't pronounce your last name, Dr. Michel, so I apologize to that. Now, his project, Post-Visit AI, is an AI tool designed to help patients understand and act on what happened in their appointment. So the narrative here pretty much writes itself. Not a Stanford computer science graduate or dropout, as they tend to be, not a Silicon Valley founder, but a clinician who sees every single day what happens after the consult ends. Patients leave overwhelmed. The instructions he's given are probably blurry in their head. There's follow-up plans, but they get fragmented, and the experience is less good than it should be for many patients. So now, thanks to these tools that are available, Michel was able to build his project in only 7 days while he was working full-time at the hospital. Now, I love this story as an inspiration to the 50 people who will be participating and building at the RACGP Hackathon. But I also love it as a case study to show what can happen when you have domain expertise with these new generative AI tools. It's just so atypical to what we see usually in healthcare, which is this incredibly slow innovation cycle. What do you think about this one, George?
This has been a really interesting story. It's been both exciting and a little depressing. To your point, I mean, obviously his surname of Polish background. I have a couple of friends of Polish background. I can never get their names right either because they seem to have the 7 consonants in a row. But Dr. Michel is an amazing guy. And that's where the depressing part is, because watching him and watching the video of the work he did to produce Post-Visit AI and by the sounds of it, a number of other applications whilst working full-time as a cardiologist in a cardiology lab. I mean, unbelievable. Makes you feel,
What did you do?
well, what am I doing? What did I do yesterday?
Right.
So kudos to him. And I think, kudos again to Anthropic for having these sort of hackathons where they promote across a broad spectrum. And obviously healthcare is an important part of that. Come in third across 13,000 applicants using Claude, which is definitely one of the premier AI tools out there. The other thing, of course, it just demonstrates how important it is to have clinician engagement in the design of these tools. I mean, he's solving a real life problem that he sees every day in his practice. And the fact that he can do that using existing tools to code in 7 days. Now, when he says he codes in 7 days, he was coding on trains, he was coding on planes, he was coding in between cat labs. I mean, unbelievably productive guy who's obviously well-driven. But again, not untypical of the type of people who get into medicine. They really go into it with passion and energy. And we've failed to do is provide them the opportunity to focus that passion and energy into areas where they can make a huge difference, like this solution does, versus, tying them up in red tape and bureaucracy and stopping them from being able to have their full effect. So RSCGP is great during the hackathon. Hopefully we'll have our own version of Michelle pop out of that hackathon and we'll have a good news story to talk about from there. But the mere fact that the tools enable these things to happen in these sort of timeframes and people know how to use the tools. I mean, there's lots of tools out there. I think one of the things we need to do is provide better ways of informing people about the availability of these tools. And that may well be something that we can take under our wings at Pulse.
Oh, absolutely. And I think what this shows is, and it's not perfect by any means. There's governance questions, safety, compliance, integration, all of that stuff. But that's not the point of this story. This point is really, if you deeply understand the workflow, if you deeply understand what's the problem, there's actually now a suite of tools that are, yes, today is the worst they're ever going to be, as we keep saying when it comes to AI. There's now this suite of tools where you can take that deep domain knowledge and apply it to actually helping address these challenges and these frustrations and these opportunities. And so the idea that you need to have technical knowledge, coding knowledge, that you need to have a heap of money from investors to build something, these things are no longer barriers to entry, at least to get started, which is really exciting. And I think we're just going to see more and more of this really groundswell of innovation happening. And hospitals are going to have to work out how they manage all of this. We will be talking about that in future episodes, I'm sure. But as inspiration, I think this is a really cool thing.
Yeah. The one important point we do need to keep in mind is that we still need to make sure that we standardize our data models so that we don't have thousands of applications popping up with their own unique proprietary data models. So things like OpenAI and those sort of tools are really essential for us to understand that we can innovate, but based on a standard. And again, I haven't looked into detail whether that this goes down that road. But the reality is, if we have 1,000 applications, each with their own bits of data in their own digital silos, we're going to go backwards. So we need to focus on digital standards. And one of the things that grabbed my attention whilst I was in Athens was the number of times that the Spark initiative in Australia was mentioned by various speakers as one of those standout events. So it made me quite proud as the only Aussie in the room to sort of point out that the growth of standards and standards-based infrastructure is important.
Oh, I'm so pleased to hear that. And yes, as for the Sparked crew, doing such great work. So if you're a startup listening to this show and you're going, what's FHIR, what's Sparked, what do you mean open data models, find out. Email me if you really can't find it on your own. But you need to get involved in these communities because there's also a commercial reality, which means getting involved early will actually help your business as well.
Okay, time for a quick break. And when we're back, we're going to be talking about one of George's favourite topics, Star Trek and the tricorder device.
Now, following on from those things, one of the things that I was reflecting on is that, yes, there's one thing to win a hackathon or to do well, but that's just the beginning. If you really want to change healthcare, great, build something, build it in a hackathon. But our next story is a good example of how that's just the start of the journey. Now, this story comes from the medical journal, The Lancet, about a trial of a medical tricorder in the UK. Now, George, you're an even bigger geek than me, so I thought I would hand over to you to tell the Pulse Potties who don't know what the concept of a tricorder is all about. Could you please enlighten us?
Well, first of all, I'll start off with that famous quote by Dr. Spock, live long and prosper. That's the Star Trek motto. The tricorder was something that was introduced in the very early Star Trek episodes. It was a little box. In the early episodes, it looked like a Polaroid camera, and they would scan it over a person and it would basically come up with a diagnosis. It was the AI and IoT and everything embedded into this, amazing device. And as Star Trek progressed, the tricorder improved and they could use it for scanning an environment and scanning a human, and doctors use it as their primary diagnostic tool. It's an amazing concept which people have sort of dragged on and sort of tried to name any new device that comes out into healthcare as a tricorder. It's not quite there, but it's a cool concept.
It is. And there's a whole thing. We'll put a link to it in the show notes, actually. We have no time to go into it today, but there was even a tricorder X Prize as well, probably 10 years ago now, if not more. But the idea, handheld device, and it helps you diagnose or to understand what's going on. Well, okay, so this particular tricorder, as written in the Lancet, was a cluster randomized trial that evaluated an AI-powered stethoscope for detecting heart failure. Now, it was a huge trial. 205 primary care practices participated. 1.5 million patients were enrolled, and there was an intervention group and a control group. Now, this technology, it works. It wasn't to test whether it works. It works. It's got regulatory approval, strong clinical evidence behind it. And in the trial, the clinicians who used the AI stethoscope detected 2.33 times more heart failure, almost 3.5 times more atrial fibrillation, and nearly twice as much valvular heart disease. So the tech works. So why is this a story we're talking about today on Pod? This is because the but here is that the majority of clinicians didn't actually use the stethoscope. And within 12 months, 40% of practices had stopped using it altogether, which means all these patients that could have benefited from the use of this stethoscope, that works, didn't get those benefits at a population level because clinicians basically didn't make time and they didn't adjust their workflow. They said that the 15-second recording that needed to be factored in would have added time to their already stretched consultations. So basically, they felt it got in the way. And the closing sentence in the paper, I just quote from what the authors said, the lesson of tricorder is not that AI does not work, but that in primary care, it will only work if implementation is mandatory, if it's integrated into the EHR, if it minimises the documentation burden and target patients in whom the potential yield is higher than not using it. So, George, I was like, this is a fascinating story. Plus, I love it. It's a tricorder-related device. What are your thoughts on this one?
I did find this story fascinating. So the device itself sounds great. It sounds like it does a lot of cool stuff that's really necessary. And having worn a stethoscope in the past and listening for valvular heart sounds and those sort of things is quite complicated. The ability to diagnose atrial fibrillation, which is a huge issue in the community. I mean, we really don't take into account how many people who have had strokes have had undiagnosed atrial fibrillation, which could have been picked up quite easily. And I reflect back in Australia a couple of years ago using the AliveCore device, which is nowhere near as sophisticated as what this device does. It was a simple little device that enabled you to do a one-lead ECG, which is, in the clinical world, it's not considered to be the gold standard. But in this case, pharmacists were given this device to basically screen people coming into the pharmacy, and they picked up a lot of cases of atrial fibrillation in the community. Atrial fibrillation is a funny disease. It sort of comes and goes. So you may go to your doctor and your pulse will be regular, but at 3 o'clock in the morning, you'll have a short bout of atrial fibrillation. Even those short bouts of atrial fibrillation can significantly increase the risk of stroke. So that's one example. Then heart failure is another example of where if not picked up early, often the first time heart failure is picked up is when someone's gone into hospital with pulmonary edema caused by their heart failure. So their lungs are full of fluid, and that's the first time they're picked up with heart failure. The fact that the technology is capable of picking that up but wasn't used is interesting. Now, whether the general practitioners thought it was superfluous, they were already pretty good at picking it up. The fact that the number of pickups was increased by 2 to 3-fold when using the device, I think should reflect back on them that their current methodology doesn't work. I think the problem was here is that we tried to force feed it into an existing workflow, which we all know is already inefficient. The pharmacy model in Australia, where it was used in the community to screen for people who needed to be escalated to the next level, I think that's where the failure was here. This was probably something that should have been used outside of general practice to bring people into general practice who needed the ongoing care. Now, the reality is, if they did this on every patient and only 5% of them came up with a result, they probably felt that the other 95% was a waste of time and energy. But that time and energy probably could have been used by another part of the healthcare system. Goes back to our discussions we've had over the years about redesigning the system. At the moment, we just try to squeeze things into existing consultation models. And we all know general practice consultation models here in Australia and obviously in NHS are stretched for time. They just don't have time to spend with the patient here because the reimbursement models doesn't support it. In the UK, because they have volume numbers they have to meet. So again, this demonstrates the need to rethink the healthcare model, not necessarily say the technology doesn't work. It's the model has to be adapted to take advantage of what we have available at the moment.
Yeah, and that's why when we came up with this podcast idea, it wasn't just going to be talking about technology. It's going to be talking about people, workflow design, implementation science. A lot of the technology problems have been solved a long time ago. We're not universal, but they have been for the most part. But understanding healthcare and how healthcare works and the pressures that are on the system and on the individuals. Doesn't matter how great your tech is. And if it works and, hey, it's going to save lives and it's going to be great, it's not enough, to be honest. You need to look at actually making sure that there are these workflows that don't require additional steps or parallel workflows, or you need to reinvent the workflow. And so, I'm sure if this device wasn't a separate app and this 15 seconds, and if it did it automatically and put the information straight into the patient's medical record, I bet the take-up would have been a lot more. A lot of lessons here. A lot of clinicians who are listening would be nodding their heads right now and going, yep, sort of sucks. That does not surprise me. But there'll probably be some startups listening and tech people listening going, what? So we wanted to bring this to your attention. I thought it was a nice fit with the hackathon coming up and our previous stories here about innovation.
Absolutely. And again, to add to the discussion earlier around data standards, if this system was able to automatically import that information into the EHR, use it as part of an algorithm improving care, you would have seen a different outcome. So you need to think about the whole system.
Yeah, that's right.
All right, George, our next story is probably less a hot topic, but more a curiosity. I'm talking about emojis appearing in electronic health records. And this was a study that was published in JAMA Network Open. It examined 5 years of data from Michigan Medicine, and they found that emoji use in clinical records, it's very rare, but it has increased 5-fold between 2020 and 2025. We're talking about everything from the ubiquitous smiley face to symbols for pills, eyes, and mysteriously the maple leaf. If you look at the paper, and I'll put a link to it in the show notes, there's like all of these pictures of emojis and how often they showed up. I didn't see any eggplants, so that was at least good. But anyway, now the health service in question, they actually have a policy against using symbols in medical records, but they show up anyway. And medical records are legal documents. They're clinical artifacts. They're meant to be precise, although we know that they often are not. But we know that they are often incomplete and contain large quantum of errors. But thinking about what emojis is doing in these records is something I honestly had never given any thought to until I saw this study. And there's no data standard for emoji use and interpretation in medical records, George. Do you think we need a health terminology server for emojis? Like, where's this going to go?
It was an interesting article. Kudos to the publication for publishing an article which is probably left of field. Look, you've got to love emojis. Emojis have taken over the world. But I have to say, as an older person with presbyopia, when I get a message on my phone with a bunch of emojis on it, sometimes it's hard to tell the difference between a smiley face and an eggplant. And I'm told an eggplant doesn't mean I need more vegetables. It's more to it than that. So, yeah. And when I press those little buttons, sometimes it's hard to work out what I'm sending. So I think we need to be careful with emojis.
We do. George, I have to tell you, just to jump in, sorry, it was so funny. After Dad had died, my poor mum went and got a smartphone. And so she was sending us stuff and sending to her friends saying how sad she was. And she thought she was using the crying emoji and she was doing the roll on the floor laughter emoji. We had to correct Erica.
Yeah,
Well, how many of these stories have you sent? That's not the right emoji.
To her defense, teeny weeny little emojis on a teeny weeny little screen are a little hard to see. Once upon a time, a thumbs up was about as much as we got.
Yeah.
And it's interesting that they actually comment. The thumbs up is one of those classic emojis, which means different things to different people. Like in some cultures, it's actually quite rude to stick a thumb up at people. And in other cultures, it's a job done. Or does it mean I've read it? Or does it mean I've done it? Or does it mean I agree? Who knows? So there are all those issues. And whilst the lighthearted review does demonstrate a couple of things. One, despite the policy, when you think somewhere like Michigan Medicine would have some sort of way of managing people's use of following policy, clinicians didn't. And they managed to get an emoji into a medical record, which in itself can't be that easy because the average keyboard doesn't have emoji buttons. So interesting to see how that's done.
I'll have to show you, George. You can actually do them on a normal keyboard.
Okay.
Yeah. There's a button you press and then all the emojis come up. I must admit, I don't often send without at least one emoji in it.
Yeah.
Uh-oh. Am I in trouble now?
But what it also demonstrates, and something we talk about a lot in our podcast, is data standards and interoperability. We really don't have standards about how clinical notes are written. And if you start adding emojis and non-standard terminology and bits and pieces that aren't capturable in a system, we've got problems. When I was at med school, we were taught how to document using SOAP. Subjective, what the patient tells you. Objective, what you observe. Assessment, what you think about the information. And plan. Very structured way of documenting. We do that in med school because you get passed or failed depending on how good your report is. But then once you go in the real world, then that really starts falling apart. And one of the big questions we often ask is that, who is the medical record for? Once upon a time, the only person who ever saw the medical record was the person who wrote it. Now we're sharing that medical record. It's become part of our data infrastructure. So we need to start thinking about what it is we're sharing. If we're just passing around gobbledygook, we're just clogging up data pipelines with stuff that's useless. And this is where AI scribes may play a role. We've seen some interesting work where they've been able to capture information and standardize it. That's really important. The challenge has been how accurately that's done, and we've seen pros and cons, and that's going forward. So I think one of the things we really need to focus on is how do we document in healthcare? What does that document look like? How do we make sure it complies to data standards so that it can be openly shared? And I think this is where one of our very early discussions with Liz Salmer from Open Notes in the United States, one of the things the Open Notes did very well in the United States was reveal some of the shortcomings of some clinicians' clinical notes. And that in itself prompted them to improve the quality of their notes because not only are their peers seeing it, but their patients are also seeing it. And you don't want to be the butt of a joke at the next medical conference and go, "Did you look at Dr. Smith's notes, how he uses emojis?"
That's right. So any listeners out there, have you seen emojis in medical records? Have you done it yourself? Have you given any thought to this? I would love to hear from you because, I thought this story, as I said, more of a curiosity than necessarily a hot topic, but something that I thought was really fun. And we talked to Guy from Evidently recently on the show, and we didn't really discuss it with him, but another startup that Guy has is a terminology server called Echidna. And so I'm like, we need to get Guy back so I can say, right, do we need here's another business opportunity, build a terminology server for emojis.
Add emojis to the terminologies. That will make it interesting.
George, I should let you get back to enjoying your time in Greece and getting ready to head off to Barcelona. So thanks very much for joining us and making time on your holiday to join us in the studio.
I always look forward to opportunities to join you on the Pulse Pod, Louise.
Thanks, George. All right, would you like to read us out?
Sure. So thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurik of Octopod Productions. Thanks to Emily Mara for her support. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcast. Visit pulseit.news to catch up on the news from Australia, New Zealand, Ireland, and Barcelona and Athens as well. Send any feedback or topic suggestions to pulsepod@pulseit.news. We love to hear what's on your mind. Yassas.
Yassas, George.